Good afternoon, everyone. Welcome to today's webinar. I am Dr. David Kanashko, the Director of Education and Training here at BioFlex. Today's webinar will be starting shortly in about 10 minutes. I just want to do a sound check. I noticed some people have already registered and are logged on. If you can just type in a message letting me know that you can hear my voice, I'd very much appreciate it. So once again, the webinar is on foot and ankle conditions. We'll be starting in about 10 minutes, and just type in that you can hear me if everything's good with the audio portion. Thanks very much, and we'll see you soon. Hello again. I just wanted to do a sound check. I haven't received any responses. I just want to make sure that you guys can hear me. Please just type in a message saying that you can hear the vocals okay. Once again, a sound check. If you can just email or type in a question saying that you can hear me okay, I'd appreciate it. Thanks very much. Okay, I'm back. So we're going to start the webinar. And before we start, I just wanted to thank you all for joining me today. My name is David Kanashko. I'm a chiropractor. I've been working here with the BioFlex team for about 6 years, and I'm the Director of Education and Training. Hopefully everyone can hear me okay. I did get some feedback that you guys can hear me, so hopefully that's the case. And a bit of housekeeping, if you want to revisit this webinar or any other webinars, you can go to our support page at bioflexlaser.com and you can pull up archived webinars. That goes for any future webinars as well. All right, and if you have any questions as we go along, please type them in and I'll try and get the questions at the end of the webinar. Okay, so today's topic is laser therapy for foot and ankle conditions. I'm going to discuss plantar fasciitis, ankle sprains, calcaneal bursitis, Achilles tendinopathies. And at the very end, I'll just talk about a recent paper that was released, not related to ankle and foot. However, I thought you guys would find it very interesting. I've chosen these topics because I find that these are some of the more common conditions that we see here at our clinic, and they can be challenging at times, and we'll discuss some of the etiology and pathophysiology and just a bit about understanding how these treatments can respond to laser therapy and perhaps some other things you can do as well to help your patients respond as quickly as possible. So let's start off with plantar fasciitis. I'm starting this one because it seems to be the most common condition that we see of the foot, along with Achilles tendinopathies. Now the plantar fascia, as I'm sure you all are aware of, is a thickened tissue on the sole of the foot. It has its origin at the heel spur of the calcaneus, sort of more towards the medial aspect of that area of the calcaneal bone. And then of course it fans out into the different digits. The plantar fascia is notorious for healing very slowly and therefore ends up being a very difficult condition to treat. Here's what it looks like in real life on a cadaver. You can see that the fascia is glistening white, so it has very poor blood supply. This is in fact why fascia and ligaments heal so slowly, is because of the poor vascularity of the tissue. The most common areas of pain associated with plantar fasciitis tends to be, as shown here, most commonly in the red portion circled, sort of shifting towards the medial tubercle area around the blue circle and into the fascia or the sole of the foot indicated by the green portion. So generally speaking, this is the most common area that you'll see that, excuse me, that patients do respond, or sorry, do have pain associated with plantar fasciitis. The pain is caused by a degenerative irritation at the insertion of the plantar fascia, and again, typically on that medial process of the calcaneal tuberosity. The etiology tends to be multifactorial, and the reason why I'm going to discuss this a bit at length is that you need to address the factors causing the plantar fasciitis in order to be successful with treating this condition. If you just treat the condition in isolation, I'm afraid that most patients don't respond or respond poorly or have the actual fasciitis occur over or reoccur over periods of time. Much more commonly it's due to actual trauma itself, but again it tends to be more of an overuse or overstress scenario. The numbers are quite staggering. In the United States, the stats are 10% of the population experiences bouts of heel pain, typically due to plantar fasciitis. So that's a lot of people roaming around with plantar fasciitis that need help. It occurs most commonly in females. They're not quite sure why. Typically aged 40 to 60, sort of in midlife, and the ratio is approximately 2 to 1 with respect to female to male ratio. Plantar fasciitis accounts for about 10% of runner-related injuries and about up to 15% of all foot symptoms requiring professional care. So it's a big portion of what patients present with foot and ankle pain. Plantar fasciitis occurs more commonly if you have excessive pronation, if you have excessive high arches or pes cavus, and if you are a person that tends to walk for long periods of time, standing for long periods of time. You do a lot of running, a lot of training with running for long periods of time. And all of these are made worse if those activities are done on hard surfaces. Another predisposing feature is the fact, of course, is age. I mentioned the 40 to 60 age bracket, but also with age comes heel fat pad atrophy, and this, of course, increases the stress to the plantar fascia. It also occurs more commonly if a patient is overweight. That makes sense because you have increased tension to the plantar fascia. If you wear shoes that aren't fitting properly or worn out, especially in running, and I'll mention that very shortly. And also if there's lots of training errors. These errors tend to include all of a sudden increasing the distance that you're running, the intensity and duration of your running. If you're now including speed workouts, workouts running up hills, running indoors, especially that are poorly cushioned surfaces. It also occurs more commonly if you train in lightweight, minimally cushioned shoes, which seem to be very common nowadays with all the different manufacturers. And in fact, they're finding a higher incidence of plantar fasciitis because of the poorer support in these minimally cushioned shoes. Also, you have to look at, is there leg discrepancies? Is there excessive lateral tibial torsion or femoral anteversion? These can all alter the running biomechanics and increase plantar fascia stress. So again, these all should be looked at and addressed. If your patients are coming in with plantar fasciitis, you need to look at all of these things in the history in order to help these patients and not just doing a treatment like laser therapy. You also have to look at their musculature with respect to tightened hamstrings, gastrocs, and Achilles tendon. Another predisposing factor is decreased dorsiflexion of the ankle complex, and also if there's any weakness of the gastroc, soleus, and intrinsic foot muscles that are used for stabilization of the foot and arch complex. The typical presentation is sharp pain that tends to be localized at the anterior aspect of the calcaneus. We all know that the pain tends to be more severe or most severe in the morning with initial weight bearing. And in the early stages of plantar fasciitis, the pain is typically experienced after and not necessarily during exercise. So that's also an important feature to understand. Plantar fasciitis may be associated with heel spurs or exostosis, but it's kind of a myth that heel spurs are a big part of this complex. In fact, they usually aren't. And many people actually have spurs that are completely asymptomatic. So just because an x-ray is done and that patient has an exostosis or a heel spur and they have plantar fasciitis, it's probably the plantar fascia that's causing the pain and not necessarily that spur. Treatment varies quite widely for plantar fasciitis, and it tends to be very frustrating. However, most patients, if treated accordingly, will respond. That is, about 90% will respond to non-operative treatment. Surgery is a last choice and typically isn't done unless it just doesn't get better after 10 to 12 months. The most common treatment tends to be stretching, and this is helpful in most cases, so you should make sure that you are mentioning about stretching exercises. Less effective, and certainly one I don't recommend, are NSAIDs cortisone injections. However, they're still routinely done for heel pain. Stretches are typically done for 10 seconds and repeating up to 20 times. And you can see some examples of the stretches here. Of course, you can find many other examples on specific websites or in your training that you've already had. There has been some research into laser therapy and plantar fasciitis. I want to share one article. This specifically looked at a randomized controlled study, which is why I want to bring it up. The patients were 69 in total. It was some received placebo and others received the laser. They looked at VAS from 0 to 100, and foot function index as well was measured. What was really interesting was they looked at the fascial thickness before and after laser treatment. So they used a Doppler ultrasound and they measured the thickness with the ultrasound And presumably, one would expect that the thickness of the fascia would decrease if the condition was progressing and getting better. So this compares the laser portion of patients, that is the test portion, which is at the top, to the placebo laser, which is at the bottom. This is VAS, specifically the change in the pain. So in other words, by the endpoint of the testing, the patients that received laser therapy had almost a 30-point decrease in their VAS or pain scale over the course of treatment, whereas you can see in the placebo group that was about 5. So quite a significant difference with respect to laser-treated and placebo laser-treated participants. Specifically, if you look at the VAS, you can see at baseline was 69.1 for the laser group, and at the endpoint was 39.5. That was out of 100. And the placebo group started off at about 68 and finished off at about 62. So not really much change in their pain and their heel. So again, that's a very good indication that laser therapy was very helpful in this specific study. When they looked at the plantar fascial thickness, they noticed that the patients that received laser therapy had a mean decrease in thickness of 0.4 millimeters, which was statistically significant. However, the placebo participants, that is the ones that did not have any laser, had a mean change of 0.1 millimeter, which was not deemed statistically significant. So in other words, with laser therapy, it actually decreased the thickening of the plantar fascia. And that's really important understanding mechanism of how laser therapy works. So it's a great objective way for research to show us that laser therapy can reduce fascial thickening and therefore help with signs and symptoms. Okay, so how do we treat plantar fasciitis? Well, let's look at the protocols that we use. You can see here we start off with the red LED array, a continuous wave, and the infrared is pulsed anywhere from 10 to 20, between 30 to 90. We'll start at 10 to 30 if it's a relatively acute scenario. If it's not as acute, we can start to creep up maybe 2040, 2050, that kind of scenario. You can see that we do 2 placements. I'll discuss where those are very shortly. And then we'll use the laser probe, typically set at about 40 to 50% of power. Anywhere from 6 to 7 minutes should be adequate. And if you do have a red laser probe, that's also very beneficial to do at the same time or just before the infrared laser probe, again for about 6 minutes. And then you can follow the progression from stage 2 to stage 3 if the patient requires it. Most of the time, the patient will be resolved somewhere between stage 1 and stage 2. So as far as placements, one that we'll always do is along the length of the fascia, so on the sole of the foot as in number B here. And the second one that's most commonly done is overlying the heel itself, whether it's in position C or position A, it doesn't really matter, but it is very helpful to treat that calcaneal region a little bit more than just in the one placement. My preference is to use C because that will get a bit of the Achilles tendon as well, which tends to be a common problem in association with plantar fasciitis. So those are the 2 placements that represent the 5 and the 6 and the 5 and the 6 place minutes for the dual red and dual infrared placements. As far as the laser probe goes, well, you obviously want to focus a lot of the laser probe around the origin of the plantar fascia on the calcaneotubercle, especially overlying the medial portion. Excuse me, I have a little tickle around that medial tubercle, and then of course along the fascia itself, especially along the medial aspect of that plantar fascia. But you'll palpate the fascia and treat the laser probe in any areas that tend to be sore or painful in your patient, and you're going to want to hold the laser probe for at least 6 to 7 seconds, if not sometimes as many as 10 seconds in one spot before moving it to the next one. Ankle sprains. So Ankle sprains occur obviously either on the lateral medial side. Review of the anatomy, you do recall that the lateral ligaments tend to be weaker. There are ligaments that connect the fibula to the talus, the anterior talofibular, the posterior talofibular, and the calcaneofibular ligaments. Whereas the deltoid ligament on the medial side is much stronger. It has 4 portions to it and tends to be less commonly sprained. A grade 1 sprain is considered a mild sprain, which is very slight stretching or tearing of the ligaments. So the patient will have mild tenderness and swelling around the ankle. In a grade 2, which tends to be more moderate, probably what Valanciunas had with the Raptors recently. I don't know if you watched the game last night, but he did return and played. He would have had a moderate grade 2 ankle sprain. And of course, there's moderate tenderness and swelling around the ankle. So if you look at a moderate ankle sprain, this is kind of what it looks like. A fair amount of swelling and hematoma. And by the way, with Valanciunas, what they did was they made sure that his ankle was always wrapped very tight, and they were very aggressive with trying to clear out the edema and the swelling in that ankle, and they did a lot of mobility exercises. I don't know if they did laser therapy. They won't say, but I'm pretty sure they did because we know that laser therapy reduces edema, and I'll show a research paper that that mentions this fact, which is really important in trying to get a professional athlete back to playing as fast as possible. Notice the ligaments that are torn in a moderate ankle sprain tend to be the anterior talofibular ligaments and the calcaneofibular ligaments. So when you're treating this type of scenario, make sure you use the laser probe in these 2 spots more so than the posterior ligament, which is much less likely to be damaged in a grade 2 sprain. In a grade 3 sprain, obviously it's a complete tear of the ligament. There's significant tenderness and swelling around the ankle, and there'll be a fair amount of instability that can be checked with orthopedic tests. As far as grade 1 inversion ankle sprains go, the etiology obviously occurs with excessive inversion and plantar flexion and adduction. So this stretches and tears the anterior talofibular ligament, and we've already reviewed the signs and symptoms. In a grade 2, there's a lot more force that leads to a greater degree of disability, and typically you'll see quite a few days of lost time with that patient. So again, Valanciunas was out, I think, 17, 18 days before he could get back to playing professional basketball. By the way, it's not uncommon to hear a pop or a snap because usually the anterior talofibular ligament completely ruptures, and that's where the popping sound would come from. Grade 3 is obviously a lot less common, and it is extremely disabling. Oftentimes these patients need to be seen by a physician and possibly a surgeon for repair if this is the extent of the damage. And you see damage of both the anterior and posterior talofib ligaments and the calcaneofibular ligaments, as well as a joint capsule. So with these conditions, you have a lot more severe pain. Oftentimes the patient is not able to bear weight. Make sure the patient gets x-rayed to rule out any concomitant fracture as well. And you have positive talar tilt and anterior drawer tests along with this condition. So eversion ankle sprains are much less common, about 5 to 10% of all ankle sprains. And that is because the deltoid ligament tends to be much stronger, and there's also a bony block as well that prevents excessive stress to that portion of the medial ankle complex. Okay, so let's take a look at this research paper. It was done in 2004. They looked at 47 soccer players. They were all diagnosed with second-degree ankle sprains, and they were divided into 3 groups. Group 1 received rice only. Group 2 received rice and placebo laser, and Group 3 received rice and laser therapy, 820 nanometers and 40 milliwatts of power. They measured the ankle volume. So in other words, they were measuring the amount of swelling, edema, after the first treatment, 24 hours, 48 hours, and 72 hours after the treatment. Okay, so that what they were interested here is the functionality of how laser therapy might be able to help the swelling of a fairly significant ankle sprain. Okay, and you can see the results here. If you look at the volume of measurement after 24 hours, you can see the change in RICE, in the placebo, and in the laser portion treatment. So in other words, what they did was they submerged the ankle into water, and they measured how much water was displaced. And the higher amount of volume that was displaced means that, of course, that swelling was starting to be reduced. That change in volume, okay? And you can see after 48 hours, the RICE, the placebo, and then the laser starting to increase. If you compare before that, that was 40. Now we're at 56 milliliters of volume, where if you look at the other two, is a very slight increase. And then after 72 hours, you can see now there's a change in volume average of 65 milliliters compared to the control, the RICE, and the placebo laser. So quite a significant increase in change in volume of the edema, that is loss of edema over time. So they looked at the results, and the group treated with RICE and laser therapy presented with a statistically significant reduction in the volume of edema after 24, 48, and 72 hours. And they concluded that low-level laser therapy combined with RICE can reduce edema in second-degree ankle sprains. So our approach to treatment of ankle sprains, we want to treat all the way around the ankle joint complex. So typically we'll use A and B to cover around both the medial, lateral, posterior, and anterior aspect of the ankle joint complex to affect the edema. That's the main reason why we're doing that. Even though the ankle sprain might be on the lateral side, we still want to treat the medial side. And if it's really bad, we may also do a third placement on the inferior aspect or plantar aspect of the heel as well. We're a bit more aggressive compared to plantar fasciitis with respect to dosages and frequency. And you can see here stage 1, 2, and 3, where we typically start off at about 50-60, 50-70 for stage 1 for infrared, and then work our way up from there. And again, most of the time, we can get these ankle sprains, grade 2 ankle sprains, significantly better within 6 to 10 treatment sessions over a period of 2 to 3 weeks. As far as the laser probe goes, in the case of a lateral ankle sprain, then we want to make sure in a grade 1 and grade 2 that we focus a lot of the light with the laser probe over the anterior talofibular ligament and the calcaneofibular ligament. And then if it's a complete tear, a grade 3, then we want to make sure we treat the posterior talofibular ligament with the laser probe as well. With a deltoid ligament sprain, you can see the tibiocalcaneal, the anterior the tibionavicular, and the tibiocalcaneal and the posterior tibiotalar ligament. So these all form the deltoid ligament. And again, you want to focus the laser probe on the ligaments that tend to be most painful. Again, use your palpation skills in order to assess the specific areas of the ligaments that are most damaged, and make sure you treat those areas for at least 10 seconds or longer with the laser probe before you move it on to the next spot. Calcaneal bursitis. I want to mention this very quickly because we see a lot of these related to Achilles tendinopathies. Patients come in, they have Achilles tendinosis or tendinitis, and they oftentimes have a bursitis as well. So you need to be aware of that and make sure it's treated at the same time. There's two bursa. There's a retrocalcaneal, which is number 2. So retro meaning behind the Achilles tendon insertion. And then there's a subcutaneous calcaneal bursa on the posterior aspect of the calcaneus to reduce friction between the skin and the calcaneus. So this condition is obviously inflammation of 1 or 2 of those bursae, and it's most commonly caused by repetitive overuse and cumulative trauma. So typically you'll see these in runners with tight-fitting shoes. However, it may also be associated with Achilles tendinopathies, gout, RA, and other seronegative spondyloarthropathies like ankylosing spondylitis. In some cases, some subtendinous calcaneal bursitis is caused by bursal impingement between the Achilles tendon and an excessively prominent posterior superior aspect of a calcaneus. And basically what I'm referring to is a Hagelin deformity. You tend to see this in women that wear heels, and with friction over time, you get bony outgrowth that can impinge or put pressure on the bursa in the calcaneus region. Okay, here's a nice example of calcaneal bursitis. Our approach would essentially be to use similarly similar protocol to the Achilles tendinitis and tendinopathies. So we treat that very similar. Placement-wise, if we're just treating the bursitis, then we can typically wrap the array around that bursa, so around that posterior aspect of the calcaneus. Whether you do it in this orientation or a vertical orientation, it's really up to you. The vertical orientation would also get some of the Achilles tendon a little bit higher up as well too. So it really depends on what you have going on for that specific condition. Okay, lastly, in the last few minutes, I want to talk about Achilles tendinopathy. There's two portions of the Achilles that we need to be concerned about, the mid-substance and insertional portion. Most of the time, Achilles tendinopathies occur in this mid-substance portion. That's important because when you go to treat it with laser therapy, you want to make sure this is the area that you tend to use a laser probe most with. So there's different definitions here, a tendinopathy, tendinosis, and tendinitis. There are differences here. The most common tends to be a tendinosis condition. Tendinitis is more of an acute inflammatory process. For example, a patient went out for a run and they presented the next day with acute inflammation of the Achilles tendon. That would be Achilles tendinitis, as opposed to a chronic degenerative disorder, which would be considered a non-inflammatory yet still painful condition of the Achilles. So this pathology is estimated to be responsible for as much as 50% of all sports-related injuries, and 75% of Achilles tendon ruptures occur in middle-aged men while participating in a sport. Okay, so if you look here at the different grades, grade 1, 2, and 3 of tendon tears, you can see where those tears occur. So age is commonly associated with increased prevalence of degenerative changes. So we tend to see decreased cellularity, that is fewer and fewer tenocytes in the Achilles tendon, increased glycosaminoglycan content, and lack of fiber organization. So this causes the tendon to lose its elastic properties, and therefore the muscles have to work more with subsequent tendon changes. The symptoms tend to be intermittent initially. You get a lot of stiffness, and obviously that starts to become painful, typically at the beginnings of exercise, and it tends to lessen or decrease as the exercise continues. However, as the condition worsens, you'll start to see pain being experienced throughout the exercise, and especially towards the end of the exercise session as well. There are certain risk factors, intrinsic and extrinsic. For example, body weight, systemic diseases like diabetes, and you can see other predispositions, flexibility issues, and so forth. Extrinsic are things like certain medications cause weakening of tendons, steroid injections cause weakening as well. Frequent microtrauma, for example, in runners. Again, these are all possible risk factors and that ones that need to be addressed if you're treating patients for this type of problem. If you were to look microscopically, you would see there would be lots of immature type 3 collagen fibers, an increase in ground substance I mentioned earlier. The vascularization tends to be more haphazard, and you start to see loss of collagen continuity. So the fibers are no longer parallel aligned, making them much weaker and much more prone to tear. So here's a normal tendon with nice parallel fibered collagen fibers, and here's one that you would find in tendinosis where the collagen fibers are much thinner and more haphazard in orientation. and therefore weaker. So schematically, here's a normal tendon with the parallel aligned collagen fibers, lots of tenocytes. As the tendon ages, the tenocytes start to become, you can see the nucleus starts to enlarge and they're starting to die off. And then when you have a true full-blown tendinopathy, you start to see an increase in proteoglycan and a decrease in the cellular structure and the weakening of the collagen fibers. So if you looked at the time for typical recovery, a tendinosis takes a long time, upwards of 10 plus weeks to recover. In tendonitis, usually it's much better within even a few days to a week, up to 2 weeks. However, if the patient's presenting with chronic tendinosis recurring, it can take many months to resolve. And a chronic case of tendonitis, that is, the patient keeps flaring it up, it can take upwards of a month to 2 to resolve completely. So chronic tendon injuries are degenerative in nature and not necessarily inflammatory. So the use of NSAIDs and corticosteroid injections actually are not helpful and can actually accelerate the degenerative process. One of the important things you need to do with your patients is have them perform heavy load eccentric strength training to help increase the production of type 1 collagen. Tendon healing is a continuous process because of tension across fibroblasts causes the cells to divide and to align perpendicular and help to enhance the healing. So it's very important to make sure that tendon undergoes a certain amount of stress to make sure the tenocytes produce more collagen to help repair. And of course, that's what's important about laser therapy, is it helps in this whole process. So laser therapy is designed to improve collagen fiber organization, increase synthesis of type 1 collagen, and downregulate things like matrix metalloproteinase that actually makes that matrix that is in tendinopathies tends to be in a high concentration. So you want to decrease it. Okay, you want to increase things like insulin-like growth factor. You want to reduce the fibrosis and increases reactive oxygen species that play a role in the cell cycle responding to stress. As far as treatment goes, you want to place the arrays at the distal portion of the Achilles tendon, in the mid portion, and oftentimes at the musculotendinous junction. The actual protocols you can see here for red and infrared. We usually go continuous wave, but in an acute scenario, you might want to pulse it out at 50-50 for the red. And for the dual infrared, start off at 1030. And if it's not as acute, maybe 2050, 2070. And you can see usually we use 2 placements, and you can see the probe. Most of the time, again, the patients will respond to stage 1 and stage 2. Less frequently, we'll be going up to stage 3. The placements you can see here, we tend to have different variations as long as you overlie the Achilles tendon in the portions that are most affected. Okay, so we're at our time to finish off. This paper just came out last week, and it is a meta-analysis on low-level laser therapy for chronic non-specific low back pain. They looked at 15 studies that involved over 1,000 participants, and they actually found there was intermediate and short-term follow-up such that there's significant pain reduction in favor of laser treatment. And however, they found that the trials had to use at least 3 joules per point. So that's really important, because with the lower back, you need a lot more energy in order to induce help with the pain and inflammation. So they actually demonstrated there was moderate quality evidence, which again is really good, to support clinically important benefit of laser therapy for chronic low back pain in the short term, which was only seen using, again, 3 joules, so a fairly high laser dose intervention. So that is the webinar for today. Let me pull out to see if you guys have any questions before I let you go. Let me just see here. All right. So I see one question from Fred. Hi, Fred. Can you say a few things on subluxation of metatarsal heads, follow metatarsal heads, and resulting in damage to the plantar plates? For sure, we see that a lot. So we're talking about things like metatarsalgia or even just irritation around the met heads that have fallen. I think an important aspect there is if that patient isn't having supportive orthotics, or at least having a metatarsal pad put in place, I think that's really important. We do treat that area quite commonly for those conditions. They are very difficult and challenging to improve. They tend to be chronic, but I do mechanically think that you need to restore some mechanics of that, the actual forefoot, and help that the transverse arch so that the stress can be reduced on the Met heads. Another question from Lauren with respect to calcaneal bursitis. Do you also use the probe or just the dual array? For bursitis and all these conditions, we're going to use both the dual red and dual infrared array over that bursa. And frequency of treatments and how many weeks do you suggest? For severe bursitis, typically for severe bursitis, we're going to treat 2 to 3 times a week for at least several weeks. It would take at least a month to a month and a half to resolve, depending on the severity of the condition. All right, thanks again. Here's another question from Keith. How do you know when to move a patient to stage 1 to stage 2 in any of your treatment protocols? Again, a good question, Keith. We'll always start with stage 1 and give that some time, at least 3, 4, maybe even 5 treatments before jumping up to stage 2. However, if your patient's plateauing, let's say, for example, the patient's responded very well after 2 or 3 sessions or 4 sessions, the next session they're not, then I would then go to stage 2, or you can customize and slightly increase the parameters of stage 1, so you're in between a stage 1 and a stage 2 protocol. Question about dementia. I do appreciate those questions. However, please email me about off-related topics. I just don't have the time to get into dementia treatment. Should soft tissue work precede low-level laser therapy? I would say if you're going to do soft tissue work, whether that's ART or other types of treatment, I would say that doing the laser after, so doing the soft tissue therapy first and then the laser therapy might offer better results, but I've seen it both ways. So it's really hard to say, Keith. You might want to experiment with either or and see how the patient responds, because there's both sides of the coin there. If you're increasing localized circulation with soft tissue, then it might make it challenging to get the light deeper because of increased blood flow. So you could try both ways. Can you achieve 3 joules in stage 1? Absolutely. As far as the number of joules goes with our laser probe, if you just look at the software and click on advanced, you'll see the number of joules, and then you can divide the number of seconds in order to get that exact number of joules, at least 3 joules when treating the lower back. All right, thanks again, everyone. Nice of Craig and Lisa to be listening in out in California, and I will talk to you guys soon. Next webinar is next month, I believe the end of the month on the Thursday. Check our website at bioflexlaser.com for the topics. Talk to you then. Bye now. By the way, this webinar will be presented on our support page on our website within a week. Thank you.